Welcome back guys. Now in this video let's discuss about pancreas. Guys, pancreas, you already know that it is both exocrine gland as well as the endocrine gland. What does I mean by the word exocrine? Exocrine meaning pancreas can produce digestive enzymes like pancreatic amylase, trypsinogen, chemotrypsinogen, procarboxypeptidase, pancreatic lipase, colipase. So these are all the digestive enzymes which are produced from the pancreas. Okay, so it helps in digestion. So that function is called as exocrine function. Exocrine means production of the digestive enzyme. Then what exactly is endocrine function of the pancreas? Endocrine function meaning production of the hormones. So pancreas can produce enzymes which aids in digestion. It can also produce certain hormones, okay, which maintains our metabolism. Now, what are the different cell types in the pancreas? See, in the pancreas there are different types of cells, okay, called as alpha cells. So in the pancreatic histology you can see it is something called as islets of Langerhans, and within these islets of Langerhans there are alpha cells, beta cells, okay, delta cells, different types of cells are there. Alpha cells, beta cells, D cells, F cells and epsilon cells. Okay, epsilon cells. Now, what are these cells doing? Alpha cells secrete hormone called as glucagon. Now tell me guys, what is the function of the glucagon? See, glucagon is going to increase your blood glucose levels. Okay, every student knows from the biochemistry what glucagon will do. Glucagon increases the blood sugar levels. Okay. Next up, beta cells. Beta cells produce a hormone called as insulin. Insulin. Not only insulin, also produces amylin, a hormone called as amylin, and a waste product called as a C-peptide. Okay, C-peptide. Now, what is the function of this insulin mainly? Insulin and amylin, let's say. What is the function? Insulin main function is to decrease your blood sugar levels. Amylin of course maintains the blood sugar levels, but mainly insulin, it decreases the blood sugar levels. What about the D cells? D cells produce somatostatin. Okay, somatostatin. In the name itself it's there, statin. Statin means stop, stasis. So what it will stop? This somatostatin decreases the release of glucagon and it can decrease insulin release. Okay. Next, F cells produces pancreatic polypeptide, and the epsilon cells, especially during the fasting condition, these epsilon cells produces a hormone called as ghrelin. Now what is the function of this ghrelin? The function of the ghrelin is to increase your hunger sensation, and not only that, this ghrelin can increase your growth hormone levels. Ghrelin increases the growth hormone. In the growth hormone topic I have told you, whenever you are doing fasting, fasting produces glucagon and ghrelin. Glucagon and ghrelin, both this glucagon and ghrelin, both the glucagon as well as ghrelin, they can increase your growth hormone levels. Okay, they can increase your growth hormone levels. So fasting, ghrelin, glucagon, exercise, stress, trauma, protein meals, during sleep, especially NREM stage 3 and 4, androgens, estrogens, all hypoglycemic conditions, they are all going to increase your growth hormone. Don't forget, very important for your exam. Okay. Now, having said that, some students will have a doubt here. Sir, when ghrelin is produced? Yes, ghrelin is produced during fasting. From where, sir? See, the main source of ghrelin is not the pancreatic epsilon cells. The main source of ghrelin is stomach. So stomach is the main source. And not only that, just now I have told you pancreas also produces ghrelin. And even brain can produce the ghrelin. So what are the three sources of ghrelin? Ghrelin can be produced from stomach, pancreas, pancreatic epsilon cells and brain. Done. So these are the different cells, different secretions and their function. Now let's see what are the important things that you should know for your exam. Now from exam point of view, first we will discuss about what exactly is the C-peptide and what exactly is this amylin doing to our body. Let's begin with the C-peptide. See, C-peptide is produced in equal amounts along with insulin. Let's say here is the pancreas. Let me show the pancreas here. Let's say here is a pancreas. Now this pancreatic beta cell, it is producing one molecule of insulin. It is producing one molecule of insulin. Okay. While producing one molecule of insulin, a byproduct is also produced. Okay, if in order to produce one molecule of insulin, see there is something called as a proinsulin, matured insulin, something like that. So while producing this insulin, a byproduct also produced, a waste product also produced, that is called as a C-peptide. Okay, so can I say something like this? For every molecule of insulin that is getting produced, one C-peptide molecule is getting produced. Okay, in equal ratios. Now, this C-peptide is a waste. Where it will come? It will be excreted out of the body through the urine. It is coming out of the body through the urine. So, now let's say today in the urine, I am seeing 100 molecules of C-peptide. I am seeing 100 molecules of C-peptide. Now, by looking at the urinary C-peptide values, okay, by looking at the C-peptide values, can I estimate how much insulin is produced in the body? Yeah, if 100 molecules of C-peptide is there in the urine means 100 molecules of insulin should be produced. So, what I am trying to say, the C-peptide is a marker of endogenous insulin production. So, how much endogenous insulin is getting produced? You can know it by looking at the C-peptide values. Okay, see, let me tell you why this is important for us. Okay, how it is useful for us in the clinics. I am suspecting. Okay, I am suspecting you are having diabetes. Let's say I am suspecting you are having diabetes, or I am having doubt whether you are producing enough amount of insulin or not. So what I have to check for? I have to check for your insulin levels. Okay, I have to check how much insulin is getting produced. Now, the problem is insulin is having very short half-life, guys. The insulin half-life is very short. So I cannot directly measure the insulin levels. So indirectly what I can measure, I can see the amount of C-peptide in the blood or in the urine. So by looking at the C-peptide, you can actually know how much endogenous insulin is getting produced. Okay. So yes, it's a marker of endogenous insulin. C-peptide is a marker of endogenous insulin. Done. Next step. After C-peptide, now let's discuss about amylin. What amylin will do? Amylin delays gastric emptying. Okay, delays the gastric emptying. What exactly is gastric emptying? I have told you gastric emptying means, see, let's say here I am showing the stomach as well as the duodenum. The movement of the food from the stomach into duodenum is called as what? What is this process called as? Gastric emptying. Gastric emptying. And this gastric emptying should be always slow. Okay, it should not be fast. It should be slow. So food will be gradually digested in the intestines, gradually digested, gradually absorbed. So the blood sugar levels also will not rise suddenly. So gradually blood sugar level rises. Insulin will take care about the glucose. Now what if the food moving from the stomach? What if the food moving from the stomach into the duodenum happens quickly? What if the gastric emptying is quick? So at a time food is coming to the duodenum, quick digestion, quick absorption, that can lead to glucose spikes. The glucose spikes can actually cause the damage to our blood vessels. Okay, lot of problems. So amylin, what it is doing? It is delaying the gastric emptying process, slows down the gastric emptying process. By delaying this gastric emptying process, it prevents glucose spikes. There won't be any glucose spikes. Okay. Next, so amylin, at the end of the day, I can say it is a beneficial drug for us. Okay, amylin, I should say it's a beneficial hormone. It's trying to maintain my blood sugar levels. It's not letting the blood sugar levels to rise quickly. So that's why scientists have made a drug similar to amylin. What is the name of the drug, guys? The name of the drug is called as a pramlintide. Okay, amylin analog called as a pramlintide. In the name itself, it is, see, amylin. Okay, amylin similar to it. So pramlintide, what kind of drug is pramlintide? It is nothing but amylin. It maintains my blood sugar level. So it can be used in the treatment of diabetes mellitus type 1. So apart from insulin, the only approved drug for the treatment of diabetes mellitus type 1 is pramlintide. So know it. Pramlintide, good drug. So with this, what we have completed? We have completed the important points about the C-peptide as well as amylin. Now after this, let's discuss about the insulin, guys. Okay, let's see about the insulin. Insulin, first point number 1, it's a peptide hormone. It's not an amino acid derived hormone, or it's not a steroid hormone. It's a peptide hormone made up of amino acids. It's an anabolic hormone. So it will favor protein synthesis, lipogenesis. We will discuss. It's not catabolic, it's an anabolic. Okay, it stimulates the glycogen synthesis. Okay, no lysis. Next, where this insulin is stored? See, insulin, it is stored in vesicles. Okay, along with zinc ions, because zinc gives the stability. Okay, zinc gives what? A stability to the structure of insulin. Same, I hope you have already studied this in your biochemistry. Insulin has something called as the alpha chain, something called as the beta chain. In between them there are disulfide bonds present. Alpha chain made up of 21 amino acids, beta chain made up of 30 amino acids. So there is a structure, right? So what the zinc ions will do? In zinc ions will give the stability to the structure of the insulin. So remember it. Zinc is stored along with insulin. Fine. Now, how this insulin is released? How the insulin, we all know insulin decreases our blood sugar levels. Okay, insulin decreases our blood sugar levels. How? Let me tell you. Today, let's say you are going to have your dinner or lunch. Okay, you are having your lunch, let's say. Now, after lunch, what will happen? Your blood sugar levels rises. Okay, after lunch, the food will be digested in your stomach. So, what happens to your blood sugar levels right now? Your blood sugar levels are very, very high. Okay, your blood sugar levels are very, very high. Now, what we have to do? See, we have to decrease these blood sugar levels. We have to move the glucose into the cells. So, for the movement of glucose into the cells, what do you require? Insulin is required. So, now tell me how insulin is released. First, try to understand. This glucose, where it will go? See, the same glucose I am showing you. There are thousands and thousands of molecules of glucose, right? So, now here, let's start our topic from here. See, here I am taking the glucose, the same glucose. Now, this glucose, step number 1, it is entering where? The glucose is entering into the beta cell of the pancreas. So, this cell is the pancreatic beta cell. Highlight in your books. This is the pancreatic beta cell. Now, glucose first enters where? Into the pancreatic beta cell. Okay, glucose came into the cell. With the help of a transporter called as, GLUT2. So, right guys, with the help of this glucose transporter type 2, with the help of the glucose GLUT2, because see, glucose is a very big molecule, guys. It cannot cross the cell membrane. So, it requires its transporters. So, with the help of glucose transporter type 2, first where glucose is entering? Directly into adipocytes and skeletal muscles? No. First it will enter into the pancreatic beta cells. Okay. Now, have I already taught you? Wherever you see the word gluts, all gluts are examples of facilitated diffusion. So, here the glucose is going from high concentration to low concentration with the help of this protein. So, it's a facilitated diffusion. Okay. Now, what are these things? These are granules. Okay, you can say these are the secretory granules which contains the insulin. Here already insulin is there in the pancreatic beta cell. Already insulin molecules are there. Insulin is produced, it is stored in the vesicles. Now, what this glucose will do? See, we all know glucose enters into glycolysis, electron transport chain, Krebs cycle, helps in the production of ATP. So, this glucose immediately enters into the glycolysis and helps in the production of ATP. Okay, sir. Now, what this ATP will do now? The ATP will straight away go and blocks the potassium channels. So, now this ATP sensitive potassium channels are blocked. This is the step number 2. Glucose enters into the cell. Glucose helps in the production of ATP. ATP goes and closes this potassium channel. So, can I say the activity of this potassium channel? Okay, the activity of the potassium channel is dependent on ATP. Now, whenever more ATP available, the potassium channel will close. Okay, potassium channel will close. So, who will start to accumulate inside the cell? Now, the potassium will start to accumulate inside the cell. Potassium, which is a positive charge, accumulating inside the cell. So, accumulation of these positive charges will lead to depolarization. Okay, will lead to what? Depolarization means the cells are getting activated, the cell voltage is becoming positive. Depolarization. Okay, depolarization. Now, God designed our beta cells in such a way, whenever a beta cell is depolarized, okay, whenever a beta cell is depolarized, the depolarization opens this calcium channel. The depolarization opens which channels, guys? Calcium channels. So, calcium will start to come into the cell. Now, where this calcium will go? So, this calcium, whatever comes into the cell, the calcium will go and bind with the secretory granules. So, calcium, you all know, helps in the movement of the vesicles. Calcium will help in the movement of the vesicles. So, these vesicles will start to undergo exocytosis. The vesicles, now they will release the insulin into the blood. So, this is how the insulin is released. Understood? This is how insulin is released. Now, tell me, who is there in the blood? Insulin is there in the blood. Also, glucose is there in the blood. Okay, there are millions and millions of molecules of glucose, let's say. Now, what this insulin will do? See, insulin, it will go and act on its receptor. Where are the insulin receptors present? So, these insulin receptors are present on adipocytes and skeletal muscles. So insulin is coming and acting on the skeletal muscles and adipocytes. Okay, the insulin receptor or the tyrosine kinase receptor is activated. TKR stands for tyrosine kinase receptor. Only now, whenever this tyrosine kinase receptors are activated, only then this adipocytes or the skeletal muscles, only now they will give signal for the production of GLUT4 transporters. Now, who is implanted onto the cell surface? It's a GLUT4 transporter. So now the GLUT4 transporter are placed in the cell membrane. Now with the help of this GLUT4, now the remaining glucose molecules, okay, there are a lot of glucose present in the blood, right? Now the remaining glucose molecules from high concentration, they will enter into the cells. So glucose is going from high concentration to low concentration. So again it's an example of facilitated diffusion. And what is the transporter that is helping in the glucose absorption? GLUT4. Where is GLUT4 present? GLUT4 is present on adipocytes and skeletal muscles. Adipocytes and skeletal muscles. Okay. Now the important points which I want you to know for your exam. What is an insulin dependent GLUT? Insulin dependent GLUT is GLUT4. Only whenever there is insulin, GLUT4 is there. So can I say finally, insulin helps in the movement of glucose into the cells. By moving the glucose into the cells, what will happen to the glucose levels in the blood? Glucose levels in the blood will decrease. So always remember, insulin decreases the blood sugar levels by moving the glucose into the adipocytes and skeletal muscles with the help of GLUT4 transporter. Wherever you see the word GLUTs, all GLUTs are examples of facilitated diffusion. Facilitated diffusion. Now, questions. Look at the questions. Guys, what are the ions responsible for the exocytosis? Calcium. What are the ions responsible for the depolarization? Potassium. ATP sensitive potassium channels are present on beta cells. Insulin dependent GLUT is GLUT4. GLUT4 are present on adipocytes and skeletal muscles. Okay, so these are all the MCQs which I want you to know. Now let's integrate this with pharmacology, guys. Okay, pharma integration. See, can I say if you block this potassium channel, what is the result? Whenever the potassium channels are getting blocked, the cell will undergo depolarization. Depolarization causes the release of insulin. So you block this channel, insulin will be released. So now tell me, see, there is a patient in whom I want to increase the insulin levels. Okay, let's say there is a diabetic patient. I want to increase his insulin levels, guys. How can I do that? By blocking ATP sensitive potassium channel. So ATP sensitive potassium channel blockers, they will increase the insulin release. So insulin helps in the treatment of diabetes. So right, there are a group of drugs called as sulfonylureas. What the sulfonylureas will do? See, they are potassium channel blockers, ATP sensitive potassium channel blockers. They will increase the insulin release. So they are called as insulin secretagogues. Okay, they are called as insulin secretagogues, means they increases the release of the insulin. Okay, what are the examples of those drugs? Glipizide, glyburide, glimepiride, glyclazide. These are all the sulfonylureas which are potassium channel blockers. In the same way, use your logic. If you block this channel, more insulin is released. But if you open this channel on contrary, okay, exactly opposite. If you open these channels, the insulin release will decrease, because once you open this channel, more potassium will go out of the cells will become hyperpolarized. So potassium channel openers decreases the insulin release. Okay, so there is a drug called as diazoxide, which is a potassium channel opener. So what it will do? It decreases the insulin release. In which condition you want to decrease the insulin levels? In which condition you want to decrease the insulin levels? A condition called as insulinoma. You know, insulinoma is a tumor. Insulinoma, it's a tumor of beta cells. There is more insulin in this condition. Okay, there is more insulin in this condition. So as a doctor, what you have to do? You have to decrease the insulin. How you can decrease the insulin, guys? By diazoxide. So always remember, diazoxide is the drug of choice for insulinoma, in the treatment of insulinoma. Done? So with this, what we have completed, we have seen, okay, how insulin is released and what are the drugs which can alter the insulin release, the drugs which can increase the insulin release and the drugs which can decrease the insulin release. Okay, with this the topic of insulin secretion is completed. Now after seeing about how insulin is released, now let's see what are the different effects of insulin. Okay, how insulin is going to affect our metabolism. Guys, already I have explained you, insulin is going to move the glucose from the blood into the cells. So what is the main action of the glucose, main action of the insulin? Insulin always wants to, okay, insulin always wants to decrease the blood glucose levels, we all know that. So now I am saying insulin will activate, listen carefully, insulin, it is activating certain biochemical reactions. The insulin is activating certain biochemistry in our body which can actually decrease the blood sugar levels. You know, the main mechanism of action of insulin is to produce the GLUT4 transporter so that the glucose is going to go from the blood into the cells. We all know that. Not only that, insulin will try in different ways to decrease the blood sugar levels. For example, say, now what insulin is doing? Insulin, it is activating glycogenesis, or you can say glycogen synthesis. Insulin activates glycogen synthesis. Now, what exactly is this glycogen synthesis, guys? Glycogenesis or glycogen synthesis? Glycogenesis is the conversion of the glucose into the glycogen. Glucose will be taken from the blood, converting into glycogen. So, what will happen to the blood sugar levels? The blood sugar levels actually decreases. Yes or no? Next, what about lipogenesis? Lipogenesis is taking the glucose from the blood into the adipocytes, converting into fat. Okay. So, blood glucose levels, what will happen? Decreases because the glucose is being converted into the fat. So, next, what is glycolysis? Glycolysis means the glucose uptake of glucose from the blood into the cells, converting into ATP. Okay, glycolysis is using the glucose for the production of pyruvic acid, and during this process ATP is produced. So, what happens? The blood glucose levels will actually decrease. So, what I am trying to say, insulin is going to activate those reactions, insulin activates those reactions which can actually decrease the blood sugar levels like glycogen synthesis, lipogenesis or glycolysis. Exactly opposite, use the same logic. Insulin is inhibiting, okay, insulin, it is inhibiting certain reactions. Which reactions? For example, insulin inhibits glycogenolysis. Glycogenolysis. Now, in the name itself is there, glycogen breakdown. So, whenever glycogen is breaking down, it will increase the blood sugar levels. It can increase the blood sugar levels. No, we don't want that. Especially insulin don't want that. So, insulin inhibits glycogen. Insulin inhibits glycogenolysis. Next up, gluconeogenesis. What exactly is the gluconeogenesis, guys? Glucose newly production. New production of the glucose from the non-carbohydrate sources like proteins or fats. So, again this can increase the blood sugar levels. This can increase the blood sugar levels. So, it is inhibited. Gluconeogenesis is inhibited. Glycogenolysis is inhibited. I have taught you whenever there is insulin promotes lipogenesis. So, lipolysis, exactly opposite, lipolysis will be inhibited. Lipolysis will be inhibited. Now, till the time, trust me, till the time insulin is there in the body, the ketone body production will be inhibited. We don't want the ketone bodies. Okay, till the time insulin is there, the ketone body production will be halted, stopped. No ketone body production. So, these are the metabolic actions. How insulin is affecting my metabolism, like carbohydrate metabolism and fat metabolism. And you know, insulin is an anabolic hormone, right? It helps in protein synthesis. See, it is causing the glycogen synthesis, lipogenesis, protein synthesis, and causing glycolysis. Done? Next step. Having said that, what is the final summary? See, there are many hormones which can increase your blood sugar levels. From the beginning, I am telling you, growth hormone increases your blood sugar levels. Growth hormone is a hyperglycemic hormone. It can increase the blood sugar levels. Thyroid hormones, they are catabolic hormones, cause the glycogenolysis. When it's causing the glycogenolysis, again it's going to increase the blood sugar levels. So, even thyroid hormones, okay, thyroid hormones. Next, cortisol. Next, glucagon. Next, epinephrine, norepinephrine. Okay, so these hormones, all these hormones, they all can increase your blood sugar levels. Okay, they all can increase your blood sugar levels. All of them are examples of the hyperglycemic hormones. Okay, but the only hormone which actually can decrease your blood sugar levels is insulin. Okay, so insulin is like a lone warrior. Okay, alone it is fighting. So insulin can decrease the blood sugar levels, all others can increase the blood sugar levels. Done. Apart from this, any other important function of insulin is there? Yes. Insulin not only moves the glucose into the cell but also moves potassium. So what I am trying to say, guys, let's say here is a blood vessel. Okay, I am taking a blood vessel here. Here I am taking a cell. Okay, let's take the adipocyte here in the red color. Let's say this is the adipocyte. I have told you what insulin will do. Insulin moves the glucose into the cells. Insulin is moving the glucose into the cells. Not only glucose is moving, potassium also moves into the cells. What are the two functions of the insulin, guys? The two functions of the insulin is the movement of the glucose into the cells as well as the movement of potassium into the cells. Both will occur. Okay. So, can I say insulin decreases the blood sugar levels? Insulin decreases the potassium levels. Okay, insulin actually decreases the potassium levels. So, that is the reason why insulin can be used in the treatment of hyperkalemia. Whenever there is more potassium in your blood, you can actually decrease the potassium by giving insulin, because insulin moves the potassium into the cells. Okay. So, right here, insulin, what it is doing? Insulin moves the potassium into the cells. So, it can be used in the treatment of hyperkalemias. But it is not a drug of choice. See, drug of choice for hyperkalemia, see, drug of choice for hyperkalemia is what? The drug of choice for hyperkalemia is calcium gluconate. Calcium gluconate is the drug of choice. But I am not talking about the drug of choice. Even insulin can be used in the treatment of hyperkalemias. Okay, done. So with this, what we have completed? We have completed the actions of insulin on our, the action of the insulin on our metabolism. What insulin is doing to our, like, carbohydrate metabolism, protein metabolism, fat metabolism. Okay, and how insulin is decreasing the potassium. Next, let's see the abnormalities of the insulin. Guys, the condition that I am going to discuss with you is called as a diabetic ketoacidosis. It's a simple topic, very important for your exams. See, diabetic, the patient is having diabetes, and ketoacidosis, why it is happening. Let me tell you, see, this diabetic ketoacidosis especially seen in type 1 diabetes mellitus, mainly seen in type 1 diabetes mellitus. You all know type 1 diabetes mellitus, it's a autoimmune disease. It's a autoimmune destruction of which cells in the body? Beta cells in the body. The beta cells are getting destroyed. The beta cells of the pancreas destroyed. Now, whenever the beta cells of the pancreas are getting destroyed, do you think insulin is produced? No, there is insulinopenia, insulin deficiency, insulin nahi hai sir. There is no insulin. Now tell me, whenever the insulin is not there, do you think my skeletal muscles and adipocytes, do you think they can take the glucose? No insulin means no glucose uptake. So, now the glucose is not going into the cells, glucose is staying in the blood. Now, what happened to the blood glucose levels? There is lots and lots of glucose in the blood. Now, where this glucose will go? Glucose will go to the kidneys. Glucose is getting filtered into the kidneys, and kidneys will kick the glucose out. Okay. So, now what is happening? As there is a lot of glucose in the blood, as there is lots and lots of glucose in the blood, the glucose will be starting to go out in the urine. Okay. Kidneys are clearing the glucose out of the body. Okay. Because there is excessive amount of the glucose. A lot of glucose is getting filtered into the kidneys. Kidneys don't have the reabsorption capacity to reabsorb this much amount of glucose. Actually, now these patients are almost having more than 550, let's say, milligrams per deciliter. This much amount of glucose is there in the blood. Normally, in you and me, how much glucose will be there? 100 milligrams per deciliter or 110 milligrams per deciliter. But in these people, because the insulin is not there, their blood sugar levels are very, very, very high. More than 500, more than 600 or more than 800. Lot of glucose is there. Okay, lots of glucose is there. Now this glucose is getting kicked out of the body with the help of the kidneys. Now wherever glucose goes, water follows. Now glucose is like a sponge, guys. Glucose is like a sponge. So what this glucose is doing, it is causing the osmotic diuresis. Wherever the glucose is going, it is absorbing the water and taking the water out. So because of this, in this fellow, there is polyuria, dehydration and polydipsia. So especially this is happening in a child. Okay, type 1 diabetes is especially seen in children. Okay, type 1 diabetic people are mainly children, right? So in this child, there is excessive urination. So the baby is getting severely dehydrated and the baby is drinking more and more water. there is polyuria, polydipsia and dehydration. So main problems, the main problem with the diabetic ketoacidosis is dehydration, severe dehydration. Okay, but tell me at the end of the day, the problem solved? The cells are getting the glucose? No, they are not getting the glucose. Glucose is going out of the body, causing dehydration. Now, in this time, do you know what happens? The body have to get the energy, right? The cells have to get the energy. They have to get the ATP. So now, cells are using a different source of energy. Now, cells will start to use a different source of energy. See, glucose is one form of currency. Glucose can generate the ATP. So, when the cells are not getting the glucose, now they will start to use the fats for the ATP production. So, now there is ketone body production. What exactly is happening, guys? Ketogenesis is happening. Okay, now lipids, lipid breakdown or fat breakdown. Okay, lipolysis, I should say, lipolysis is going to happen. Why? You have to think logically. Here I have told you, till the time insulin is there in the body, there is no lipolysis, there is no ketogenesis. But right now what happened? There is no insulin in the body, sir. Whenever insulinopenia is there, insulin deficiency is there, you can start lipolysis, you can start ketone body production. So that is the reason why here in diabetic ketoacidosis, as insulin is not there, lipids are getting broken down. Fats are getting broken down into fatty acids. Fatty acids will go to the liver. In the liver, by using these fatty acids, ketone bodies are produced. What are the examples of ketone bodies, sir? These are the examples of ketone bodies like acetone, beta hydroxybutyric acid. These ketone bodies are getting produced. And the good point about these ketone bodies, say, they can produce your ATP. They can enter into multiple pathways. They can enter into the Krebs cycle and they can generate the ATP. Good, they can generate ATP. But the problem is, these are acidic substances. These are acids. So, leading to metabolic acidosis. So, what will happen to the pH? pH is going to decrease. Okay, pH is going to go down. Understood? pH is going to go down. Now, see, when you go and stand near a boy, see, this diabetic ketoacidosis is a medical emergency. Whenever you see a child with the metabolic, this diabetic ketoacidosis, you can feel the sweet breath from him because he is producing a ketone body called as acetone. Acetone is a gas, guys. It is coming out of the breath. So, it will give the sweet breath. And these people, see, already they are suffering with acidosis, right? They are suffering with acidosis. So, what they will try to do? They will try to decrease the acid production in the body. Try to understand, note, carbon dioxide is the source of acid. Okay, carbon dioxide is the source of acid in our body. So, who is the source of acid, guys? Carbon dioxide. So, carbon dioxide, you can say carbon dioxide is equal to acid. Carbon dioxide is nothing but acid. Now, already in our patient, see, already in our patient there is acidosis. Now, tell me, what you have to do? You have to decrease the acid production in the body. Already acidosis is there, right? You have to decrease the acid production in the body. If you have to decrease the acid, what you have to decrease? You have to decrease the carbon dioxide levels in the body. How can you decrease the carbon dioxide? By causing hyperventilation. So, these people with the diabetic ketoacidosis, do you know what they will do? They are doing something like this. They are doing the hyperventilation. So, that hyperventilation is called as Kusumal breathing. So, Kusumal breathing is nothing but the hyperventilation to wash out carbon dioxide. To wash out carbon dioxide or to decrease carbon dioxide. So, whenever you are decreasing the carbon dioxide, acid production decreases. Like, compensation. Like, lungs are trying to compensate, trying to decrease the acid production. Okay. So, this is called as a Kusumal breathing. Now, you understand? So, a patient who is suffering with diabetic ketoacidosis, see, why the name diabetic ketoacidosis? Because the patient is type 1 diabetic, no insulin, diabetic. He is producing the ketone bodies like beta hydroxybutyric acid. These are acids. The ketones are acids leading to low pH, acidosis. So, this is diabetic ketoacidosis, which is a medical emergency. Okay, especially seen in children who are doing the hyperventilation. The children are severely dehydrated. So, now the treatment is very important. What is the first line treatment? What you are going to do? Severe dehydration. So, the first line treatment is saline infusion. Okay, 0.9% sodium chloride. Okay, isotonic saline. It will help in hydration. And what is the drug of choice? The main problem, the whole problem is because of the no insulin, right? Insulin is not there, that's causing the problem. So drug of choice is the regular insulin. Regular insulin we have to give. And what is the most common cause of death? Especially in children, the most common cause of death is cerebral edema. Cerebral edema. So cerebral edema is considered as the most common cause of death, and that happens especially during rapid hydration. So you have to give the hydration, right? So if you give this hydration rapidly, that rapid hydration can actually cause this edema and that can lead to the death. Especially this death will happen during the treatment stage. Okay. So these are the important points which I want you to know for your exam. With this, what we have completed, we have seen the normal functions of the insulin, the metabolic functions, how insulin is helping in the movement of the glucose into the cell, the pharmacological integration. Okay. We have also seen what is the relationship between the insulin and potassium. Also the insulin disorder, that is the diabetic ketoacidosis. Hope the video is helpful. Thank you.